Thank you, everybody, and welcome to the Bolivian and Argentine Hemorrhagic Fevers webinar. We're going to go through some housekeeping items before we get started and introduce our speakers. So next slide. And so we're going to have, this is one of our first ground rounds or global rounds in which we're doing simultaneous interpretation. So please, I'm going to say this both in English and in Spanish. Para la interpretación simultánea, van a dar clic al icono de interpretación.
For simultaneous interpretation, you're going to click on the interpretation icon that you see here in one. Then you're going to choose the language that you're going to listen to the presentation in. When choosing a language other than the speaker's language, you can mute the original audio or you can hear it
so for the
in a
indication
low
for simultaneous interpretation, you're going to click on the interpretation icon, as you can see here on the screen, and then you're going to select the language in which the presentation will be listened. When you're going to choose the language other than the speaker's language, the original audio will be muted unless you select otherwise. And you can see the instructions on the screen. Next slide. If you're getting connected from your mobile device, here are the instructions to do it. Lo mismo desde su teléfono celular o desde su móvil, esta es la manera para seguir las indicaciones de cómo se conectan para la traducción simultánea. Well, and now I'm going to do the introduction to NETEC. But before I get that, I'm going to introduce myself since I started talking without saying who I was. I am Gaby Frank. I am a physician and I am the medical director for the biocontainment unit at Denver Health and Hospital Authority. That is the regional emergent special pathogens treatment center for Region 8 in the U.S. So NETEC, or a National Emerging Pathogens Training and Education Center, is a partnership for preparedness. And the mission is to set in the gold standards for special pathogen preparedness and response across health systems in the U.S. with the goals of driving the best practices, closing knowledge gaps, and developing innovative resources. In 2015, and recognizing the national need for additional biocontainment unit beds in the U.S. and laying the groundwork for a broader special pathogens response network, Health and Human Services, that is in the U.S., designated 10 regional emergent special pathogens training centers or RESPECTs throughout the country and charged NETEC with supporting the advancement of regional preparedness in the past years. In 2022, there were 3 additional sites that were designated. So now we have the number of RESPECTs to 13 from 10 that were the original. So we have clinicians, researchers, and emergency responders and other healthcare professionals from the 13 RESPECTs that bring knowledge and experience in high consequence special diseases to NETEC to meet the needs of healthcare facilities, emergency responders, and research across the country. This one can seem like a very busy slide, but it's not, and it's very important just for everybody to understand what NETEC does. So NETEC actually helps healthcare facilities and EMS agencies to prepare for special pathogens events with free virtual and on-site readiness consulting and program assessments, as you can see in your first column. We have targeted support services that are designed to match the questions with the right expert who can provide an answer based on unique needs of the organization that is posing the question. We have our online self-assessment tools that help hospitals and emergency medical service agencies evaluate their operational readiness to respond to special pathogens events. And then at the conclusion of the self-assessment, the facility or agency is usually able to recognize programmatic strength, identify opportunities for improvement, and have a roadmap for implementing strategies based recommendations from our team of subject matter experts. We also offer courses and training for nurses, physicians, emergency responders, and other healthcare professionals, equipping them with preparedness and best practices. And you can see here in our second column, NETEC also delivers education and training through webinars, podcasts, and in-person and online courses. The online courses are free and self-paced, and many of the courses and webinars are available to take for continuing education credits. We host also an online repository of resources and tools that can be easily downloaded and shared for use in your organization. When we talk about the research work, we have the Special Pathogens Research Network that has created an infrastructure to improve readiness for conducting rapid clinical research related to special pathogens in the United States, and basically provides researchers with training tools and resources to quickly understand clinical syndromes and study effective treatments and clinical management strategies. And last but not least, NETEC's international partnerships and programs that basically convenes representatives from around the globe to share best practices and experiences with special pathogen outbreaks, with the goal of establishing strategic international collaborations and advance the US and global special pathogens preparedness. So again, we welcome all of you to our talks on viral hemorrhagic fevers, and we're going to have two speakers today. We're going to have a first section of our talk that is going to be on Bolivian hemorrhagic fever, and our presenter is going to be Dr. Cristian Castellan Gutierrez, and I'm going to be doing their introductions and more detail right before they're about to start talking. And then for Argentine hemorrhagic fever, we have Dr. Anabel Sinchi. And again, these two presentations are going to be followed by questions and answers. So if you have any questions to start developing during the presentations, please use the Q&A tab at the bottom of your screen to start typing your questions so we have them ready to go when the presentations are ready. So I'm going to introduce Dr. Castellan Gutierrez, who is a physician, specialist in infectious diseases in Bolivia in the Hospital Japonés. He did his training in infectious diseases at Hospital Muniz in Buenos Aires, Argentina. And he's going to be our specialist talking about Bolivian hemorrhagic fevers today. And Dr. Castellan, I'm going to pass that on to you.
Thank you for inviting me to talk about a disease that brings us all together, especially here in Bolivia. And I'd like to thank the NETEC for the invitation to talk to you about Bolivian hemorrhagic fever. I hope you can hear me well, and we're going to continue with the presentation. Next slide, please. Very well. I am Cristian Castellan. I'm an internist. I currently am an infectologist in the Japanese University Hospital, and I'd like to thank the Internal Medicine Association and the Japanese Hospital. Very well. To give you an idea of how we're going to carry out this presentation, I'm proposing giving the description of Bolivian hemorrhagic fever. This is a very long story that starts in 1963 when we talk about initial study, but we're going to talk about this. We're also going to talk about diagnostic and what diagnosis methods we have to diagnose this disease. We're going to talk about treatment, and especially we're going to talk about prevention that we have to have when we start seeing Bolivian hemorrhagic fever. Well, this is just to locate ourselves. Bolivia is in the center of South America. We have neighboring countries of Argentina that also has a hemorrhagic fever. They have the Argentine hemorrhagic fever. We also have Paraguay, Brazil. Brazil also has a hemorrhagic fever that is a Sabia hemorrhagic fever. We also have tight contact with Peru and Chile. As you know, there has another hemorrhagic fever that we can find in the Bolivarian country of Venezuela. But today we are going to talk about Bolivian hemorrhagic fever and later Argentine hemorrhagic fever. Next slide, please. Very well. Also, to give you some context, my country is a country that has more than 190,000 square kilometers, and we have 9 departments that you can see here. And this is where Santa Cruz, this is in the lowlands, eastern plains, closely located next to Brazil. We have pleasant temperatures, 25 to 45. This is a place where there's a lot of vegetation, and people are dedicated to raising cattle and other livestock to later sell the meat. But we also have rice crops. We also have other departments, Cochabamba. This has a valley where they where they farm corn and also cattle, but in a lesser measure. We also have other departments, the La Paz, Oruro, and Potosí. These are the highlands departments, but La Paz, 2/3 of the Department of La Paz belongs to the Eastern Plains. This is the northern part of La Paz. We also have pleasant temperatures between 15 to 35 degrees centigrade, and in the valleys, the temperatures are 25 to 35 degrees. This is the distribution of my country, and over here you can see the rivers and the different elevations. Just to remind you, in 1962-63, there was a big outbreak. In reality, we did not know what it was about, and this was in a place called San Joaquin. San Joaquin is a province in Beni, the Department of Beni. This is the capital province of, and we started to see different hemorrhagic fevers cases, but we definitely did not know what was happening. So the patients started to die because of these unexplained hemorrhagic fevers, and back then the virus, the Junin virus from the Argentine country, had been discovered. So we got some medical staff coming in to help us know what this was about. This evolved, and then we realized that we had the Machupo virus. This was the one that was producing these hemorrhagic fevers, and especially we realized that what the prevention was. Prevention was the key to success to be able to fight this hemorrhagic fever. A few years later, in 2003, in Cochabamba, more or less 350 to 400 kilometers from San Joaquin, in the Department of Cochabamba, we start seeing other cases of hemorrhagic fever. We then did not have methods to have the certain lab diagnostics because we thought that this hemorrhagic fever was only present. We only thought the cases were in San Joaquin and Beni. We thought that these were unspecified virus, more leaning towards dengue, but the patients were dying, and they were dying because of blood loss. And once we saw that this was a hemorrhagic fever that had, but it was different from the one that was Machupo, the Machupo virus. So we called this the Chapare virus. Time passed. It had a very high mortality, by the way. More than 90% that contracted the serious illness died in Cochabamba, but it was it had been self-limited. In 2019, a few months before the pandemic, in April, on the 24th of April, really, we start seeing some hemorrhagic fever cases of fever, asthenia. Everything led us to suspect that this was a dengue case. We didn't really have any idea that this was a hemorrhagic fever. The first patient had been cataloged as a hemorrhagic fever, but coming from dengue. We weren't able to isolate the virus in this patient, but then we saw more people suffering from this illness, and then this caught the attention of the Ministry of Health, and they created the warning, and then there was researchers to do the study. So this is the history that hemorrhagic fever, Bolivian hemorrhagic fever has had here in Bolivia. Next slide, please. Very well. This is so that you can see that this is this shining point, the star. This is the city of San Joaquin, the capital of the Gran Mamoré province. And there were some descriptions of these hemorrhagic fever cases since 1952. But in 1959, we see the epidemiologic warning by the Ministry of Health. And there's an advanced team from the United States that comes to help us with this serious hemorrhagic fever cases. And in 1962-63, we have the causal agent for the hemorrhagic fevers. Back then, this was called the Bolivian hemorrhagic fever caused by the Machupo virus, and it was confined to this department. This was a clinical and epidemiological illness that was similar to the Argentine hemorrhagic fever. In 63, we were able to identify the Machupo virus, the Carvalho strain, that came from a sample that was extracted from the glass of a child. Had Carvalho as the last name. That's why it's called the Carvalho strain. And then a few months later, we saw that Calomis calosus, this is a mouse that lives in that area, was the one that was causing the hemorrhagic fevers, and they were the vector for this illness. So this is what we have found. We also saw that the best way to prevent this illness was fight the Calomis calosus, a small, really small mouse, really, that feeds on rice and grains and legumes, and lives in that area. We had to use a lot of rodenticides, traps, and we imported cats from other communities to be able to control this epidemic that was, or outbreak that was hitting us in 1962. In 2 weeks, the illness was controlled. It had high levels of mortality. People started to migrate. People left the houses where the illness had appeared, and so the town emptied out. People migrated out. Then there were many technical and epidemiological studies, and then there was a research team from the Ministry of Health visiting, and they exterminated and controlled the mice, the long-tail mice, or the rice feeding mice. So the disease was controlled in this manner. Even though there were sporadic cases, these were very limited to the Beni region, especially that place, San Joaquin, and there wasn't greater problems after that. The disease was controlled. Next. Very well. So what is the clinical chart for the patients? This is an incubation period that goes from 6 to 21 days, in average 6 to 12 days. This is the incubation period that the hemorrhagic fever has. The first week, patients show fever, chills, anorexia, headaches, myalgia, conjunctival hyperemia, and especially lumbago. If one looks at the hemorrhagic fevers, but this pathology evolves with time. In 1 week after you see symptoms, the patient might have some other neurological symptoms such as tremors, confusion, psychomotor excitation, stupor, and this leads to the generalized convulsions. We also see hemorrhagic symptoms. We have digestive hemorrhage. In 2019, we saw gum bleeding, and then eventually they reach a state where they have a shock, or if they overcome the symptoms, they go to a convalescence period where there's hair loss, asthenia, irritability, deafness, and memory alteration. Next. Very well. As any hemorrhagic fever, it's a serious illness. There's liver failure, kidney failure, there's bacterial infections, especially in the critical cases. And we also have intra-hospital infections that can become a problem with these patients. Next. Very well. If we talk about Calomis calosus, this is a mouse, the mouse that you can see in these in the grasslands that we have in Beni, in Santa Cruz, and in Pando. It's 180 millimeters in length. It's not a climber. It can't climb more than 30 centimeters from the floor. Generally, they get 4 to 6 pups per, and they proliferate during harvest and rain seasons. And given that there are floods in those areas, they generally go into the places where people live. This mouse can live for 2 years, and it's active generally between 6 and 8 at night. But when this mouse is having activity outside of its regular schedule, it could be sick and it could be contagious for hemorrhagic fever. It feeds on grains, seeds, corn, and it proliferates during the harvest and rain seasons. Very well. Back then, we did not know what we were facing. I mean, later, the Ministry of Health, after 2003, they gave us some indications of when we should suspect Bolivian hemorrhagic fever. But this is all about suspicious cases, and we consider patients that come with an undetermined fever that have visited or live in the endemic areas for Bolivian hemorrhagic fever in the last 21 days, because this is the incubation period. We asked them what neighborhoods they were in, where they were at, the probable places for infection. We'd write down all this data because this is a illness that has to be notified by mandate from the ministry. Next. We have to write down all the data. We have to write down the date of onset of symptoms. We have to write down where there's been unquantified high temperatures, headaches, retroocular pain. We have to fill in all of these tabs, and then we also have to consider the differential diagnostics of this possible illness. So here we have, for example, in Bolivia, we have leptospirosis, hantavirus. When one diagnoses, well, the main diagnostic for hemorrhagic fever is hantavirus, but we also have dengue, we have serious malaria, chikungunya, and Zika. And we also have seen even typhoid fever that all have similar symptoms to this illness. Next. We have a national center, reference center, we call it CENETROP, the National Center for Tropical Diseases. The personnel asks for serum or complete blood from a patient that is suspected of this illness. So we have to draw blood from the patient, and from that sample, we have to take some to the CENETROP. CENETROP is in the city of Santa Cruz. This is the algorithm that we have in CENETROP. If we have suspicion that a patient has a arenavirus or hantavirus infection, if it's a suspicious case, what the peripheral labs do, if they suspect hantavirus or arenavirus, they stop the diagnosis and they send that sample directly to a BSL-3 lab, the CENETROP in this case, and they will continue with the sampling. If the SAM patient does not, in terms of epidemiology, we do not suspect hantavirus or arenavirus. They do other diagnostic tests, for example, for chikungunya, Zika, leptospirosis, and dengue. So this is more or less the algorithm that we use here to diagnose hemorrhagic fevers. When CENETROP gets a sample, what CENETROP personnel does, they ask for a complete blood sample. For an adult is 5 milliliters, for a child 3 milliliters, with a good epidemiological chart. CENETROP is a level 3 lab, and so they get an ELISA with IgM, IgG, and also a PCR for Chapare or hantavirus. So if it's a positive case through a PCR, if we get a positive PCR with an IgG that is greater than 1 in 400, then it's considered positive for arenavirus. And if it's a PCR that is negative, but the IgM titles are less than 1 in 400 and IgG greater than 1 in 400, so we have an infection, and we coordinate with epidemiological centers so that they can research probable cases of arenavirus infection. And if we have a negative PCR with low titles and the result is negative, and we corroborate with other type of infections or illnesses that we may have, and if we do not have any positive sample, we then send it to the CDC, the center to the CDC in the United States, so that they can do the necessary processing. Thanks. So if we talk about treatment, the treatment that we do has been, what we do is we have talked about convalescent plasma that has been used for other fevers, but we are still not been able to do that. Other possibilities to control Bolivian hemorrhagic fever, what has worked most for us is controlling the vector, the mouse. We have implemented traps. We have also implemented through other measures. We also, at some time, the Machupo virus, there was cross tests. At some point, the World Health Organization said that if there was an outbreak, we could prevent these cases of hemorrhagic fever with the Argentine hemorrhagic fever vaccine. So in December 2003, as I was saying, in Cochabamba, in Chapare, 80 kilometers from the city of Cochabamba, another Bolivian hemorrhagic fever was discovered, the Chapare virus, and these are the characteristics, mostly fibromyalgia, other hemorrhagic symptoms, fatigue. So the symptoms change a little bit with this Chapare virus. They are not as characteristics as we had with the Machupo virus. Very well. This is more or less what happened in 2019 here. This is a population or settlement that is very far away from other places. It's 80 kilometers from the capital, La Paz, and there was a patient that had a chart that was similar to dengue, but after studies and then also receiving other patients, we had phylogenetic analysis, and we saw that the Chapare virus had moved 300 or 400 kilometers and had shown up here in this region in the northern part of La Paz. This is the index case. This was a patient. We weren't able to do the postmortem studies because we needed blood, but this was a 65-year-old farmer that had a chart of 14 days of evolution. Then he was admitted into the hospital, but died due to massive bleeding in the airways. So the person died. This is a comparative table. If you look at the hemorrhagic fevers, both the Argentine, Bolivian, with both Machupo and Chapare, you can see that the incubation periods for us are 3 to 16 days, but we still do not have, or back then, we still did not have a clear idea of the transmission of the Chapare virus, and we still didn't have treatment for it. In 2019, in this last outbreak, we learned that it was oligorhizimosis microtis was the one that was implied in this disease. It's broadly distributed throughout the areas of a lot of vegetation, and they also carry other viruses such as hantavirus, and it was also detected in the serum and blood of the patients that had recovered. Up to 170 days after recovery, they had present viral RNA, and in the semen it was present 87 days after recovery. So this could be a sexually transmitted illness, and patients that survived presented seroconversion, but they still had positive PCRs for blood, bodily fluids, and the swabbing that was done for those patients. And well, definitely what has changed is the fact that these illnesses are appearing in places that they weren't before, and this is due to deforestation. There's a cutting and burning of grasslands and forests, and this is leading mice to migrate to other places, making the disease traveling, and the agricultural border is expanding in the country, and that's also leading to the expansion of the illness. Some conclusions. We should suspect this pathology in patients that have charts that are compatible with hemorrhagic fevers and that they have been in these endemic areas. There's many places to be considered. Oligorisomis microtis is the reservoir for the Chapare virus in 2019. Reported in La Paz, and the permanence in this virus in bodily fluid is considerably up to 180 days after, and you can confirm transmission person to person because there were people that had not been in the fields but that had had tight contact with patients, with the index patient that were infected. So we can confirm transmission person to person, and treatment right now is symptomatic. There isn't anything proven right now. We also talked about intraimmune plasma, but that hasn't been proven for Chapare virus, and prevention is our best tool to fight this type of hemorrhagic fever. Next. And also, thank you very much for listening to me.
Muchas gracias, doctor Castellón. La verdad es que el contenido de su presentación es
Thank you very much, Dr. Castellón. A great presentation and content. We have 3 questions in the Q&A, but we're going to leave those to the end of the presentation of Dr. Sinchi. So now I would like to introduce Dr. Anabel Sinchi, a specialist in internal medicine, and she has a master's in prevention of zoonosis and head of the epidemiology department and training in viral diseases from the National Institute of Viral Human Diseases, Dr. Julio Mastegui, and member of the National Control and Prevention Program for Argentine Hemorrhagic Fever. So we're going to go with Dr. Sinchi for her presentation.
Muchas gracias, doctora Frank. Muchas gracias al equipo de NETEC por invitarnos a participar en esta Global Round.
Thank you for inviting me to participate in this, since they've talked to us a lot about Argentine hemorrhagic fever. As you've been told, it's not as different as what Dr. Christian presented when we speak of Argentine hemorrhagic fevers. Okay, next slide, please. As in the case of Bolivia, we in the 50s, in the richest agricultural and cereal producing areas of Argentina, there was a disease that emerged, an upper airway syndrome that at the beginning had a lethality of approximately 50%, that with treatment and hospitalization, we were able to reduce it to 30%. We didn't know the cause. Different groups of researchers have participated in finding the pathogen, which was found in 1958, and it was named the Junin virus because it was isolated from a patient from that locality that belonged to the area of the pandemic. At that time, it was known as the Argentine hemorrhagic fever due to its clinical manifestations, and then from that point, since the 50s, we've had outbreaks, uninterrupted outbreaks, with a progressive extension of the endemic region from the decade of the 50s. Next. Well, it belongs to the arenavirus family, arenavirus family. These are RNA viruses transmitted by rodents, and some of them cause hemorrhagic fevers both in Africa as well as in South America. Next. The reservoir of the Junin virus is the Calomis musculinus mouse. It's a wild rodent that develops chronic infections and it eliminates the virus through saliva, urine, and fecal matter in the environment. Humans are infected through inhalation or through mucous membranes coming into contact with wounded tissues and these secretions from the mouse. And although it's infrequent, there can be human-to-human transmission. Generally, the few cases of human-to-human transmission have to do with intimate contact mediating.
This is the endemic area. What you see in red in the left, this is the endemic area in Argentina. If we look at the middle map, this is a zoomed in map. We can see 4 provinces in the center of Argentina that are affected: Santa Fe, Córdoba, La Pampa, and Buenos Aires. And if we pay attention, we can see how this looks in terms of the expansion of the endemic area throughout the years. This could be explained in the map in the left. We can see the overlapping of the endemic area for Argentine hemorrhagic fever with a calculation of the distribution of the reservoir of the disease. And we can see that the reservoir is much more broadly distributed than where we are confirming cases of hemorrhagic fever. And this could explain the expansion, and it could lead us to think that we could have new endemic areas in the future. The classical epidemiological pattern for this disease is that they were 80% of the confirmed cases were happening in rural male workers between the ages of 15 and 65. But vaccination for this risk group, that is the first one that received the vaccine, changed the risk patterns, as we will see later on. Next. Clinical features can be divided, like in Machupo virus, into 3 periods. This is a representation. We have the incubation period that can be 3-4 days to 21 days. The acute period that can be divided into 2 weeks, the first week and the second week, because they have different manifestations. And finally, the convalescence period. Next. Hemorrhagic fever usually appears with an insidious and progressive progression. We see it begins with fevers, then it goes with fevers and headaches, and then later we can add retroocular pain, lumbar pain, digestive symptoms such as dizziness, nausea, vomiting, or diarrhea, and these gastrointestinal symptoms also confuse the diagnostic. And then we have discrete gingivorrhagia and epistaxis and metorrhagia in women, because that is usually overlooked because it's usually confused with menstruation. The important thing is that all these do not present signs of respiratory compromise. They have no cough, odynophagia, nasal congestion, or rhinorrhea. In the physical examination during the first week, we can also find erythematous rash on the face, neck, and upper trunk. We can also find isolated petechia in the inner part of the arms. We can also see conjunctival injection and periorbital edema. We can also have diffuse congestion of the nasal normal mucosa and also bleeding gums that can be light, and this can be accompanied from the gingival edge. There can also be an enanthema that is increased, and this can lead to other petechias. Next. So during this first week, this is the name that it was given to the illness. It's Argentine hemorrhagic fever, but the neurological signs are as important when we have a suspicion as the hemorrhage and the other main symptoms. We can see that the patient is irritable, sleepy, there can be a tremor in hands and tongue, moderate ataxia, and other symptoms that all of these are non-specific, and this delays suspicion and diagnostics. We can see hematological alterations that we see in the first week. This is accompanied by leukopenia and thrombocytopenia, and erythrocyte sedimentation rate that is normal or decreased. In the urine, we can find some alterations is the albuminuria and sediment with the presence of hyaline and granular cylinders. Generally, without treating and only maintenance, 70 to 80% of the patients can begin to improve, even without specific treatment. But between 20 and 30% of them, if they do not receive some immune plasma, could evolve to the severe form of the disease. And these are generally where we find the severe hemorrhage and the serious or critical neurological manifestations, shock, and superimposed bacterial infections. All of these severe forms are lethal in 90% of the cases. These are, for example, some of the severe hemorrhages. I'm not going to read them, but you can see them there. All severe hemorrhages have these presentations, and we have to remember that we also have severe neurological forms. For example, the patients suffer from seizures and comas in the final stages of the disease. Finally, most of the patients that recover with or without treatment show improvement around the third week of evolution. The duration of convalescence in these cases is long. It's 1 to 2 months, and it's common to find hair loss, asthenia, hearing loss, changes in memory, and irritability. These disappear progressively, and there is a complete recovery generally. However, we have to pay attention during convalescence because 10% of the confirmed cases for the Junin virus that were treated with immune plasma developed something that we vulgarly call a relapse, but it's really late neurological syndrome, which is after the person evolves favorably, they recover completely, they are released from the hospital, and then after 3 weeks, they start showing fevers and other neurological symptoms, and this has been described or associated to treatment with immune plasma, and we still do not completely know the chart. There are several hypotheses, and there's no specific treatment for this, just maintenance measures or treating the complications that appear, and generally, it's resolved after several periods of time without any specific treatment. As you can see, this was a serious economic problem for our country, aside from being a health problem, because the people that were getting sick in areas of high agricultural production or the highly productive fields that planted corn, and the harvesting of corn was done by hand. So there were no people wanting to work in those fields. And then we also had some other alterations that led our Ministry of Health, by the decision of the executive, to create in 1917 the National Institute of Viral Diseases, Julio Mastegui, that had the mission to organize a national program for control of Argentine hemorrhagic fever. This was done, or this was coordinated by the Mastegui Institute with the participation of the National Ministry of Health and of the affected provinces. Obviously, the main goal, like in any other program like this one, was to reduce morbidity and lethality of the disease. The program included a control program for hemorrhagic fever and not eradication, given that this is an area that has this is a disease as a zoonosis with an animal reservoir. Here we can see the historic evolution of the illness. We can see that in 1978, we have the National Program for Control of Argentine Hemorrhagic Fever that has been working since then. And these are some of the activities that the program implements throughout the years. They started with epidemiological surveillance, a clinical diagnosis algorithm for suspicious cases. We also had a lab diagnosis, specific treatment. It didn't just validate specific treatment, but we also installed a network for immune plasma banks and other activities that you can see here. But the landmark that changed this illness was the production of the vaccine. Having the vaccine, the first clinical trials were carried out in the 90s. It was made in the United States through collaboration with the Pan American Health Organization and the Mastegi Institute and the government of the United States. It was made in the United States, and then after the initial clinical trials, the vaccine showed efficacy of 95.5%. Once we had that efficacy, we did the study in Argentina in areas where there was a greater concentration of cases. And then when we showed the efficacy, our regulatory entity allows us to start producing the vaccine locally in Argentina, here in the Mastegi Institute. And once we had the first batches approved with the regulatory authority, we do a bridge study where we compare the immunogenicity of both vaccines in their identical formulas, just produced in different places, Argentina and the United States, and we show that both vaccines are equivalent. And therefore, in 2007, our regulatory authority allowed us to put the vaccine in the national immunization calendar of Argentina. And today, the vaccine is available in endemic areas for all people above the age of 15. As I said, another achievement of this program was to implement a non-specific algorithm for clinical suspicions, because these cases are treated empirically before lab confirmation, and we'll see why. And this is the definition that we use in Argentina. Patient with non-specific febrile syndromes that has visited or lives in the endemic area in the previous 3 weeks before onset of symptoms, of course, including other differential diagnostics. And in the medical lab, we have to evaluate if they have leukoplakia, and if they have less than 4,000 white blood cells and 120,000 platelets, we consider it suspicious, and I have to complete the epidemiological form and notify the authorities, take the sample, send it to the National Reference Lab that is also in the Mastegi Institute, and treat the patient with immune plasma. Next. The etiological diagnosis that we have here in the Mastegi Institute and in Argentina in general for many years, we have the PCR, real-time PCR, the ISCG, the neutralization test, so ELISA. So we can use direct methods or indirect methods. For those who are deceased, we use a second sample for serology. Aside from PCR, we always try to do viral isolation, but again, that can only be reserved for people who have deceased or rare cases that we have to research. We have to remember what I said, that in general, PCR, when it's positive, it's a confirmation, but it does not have a 100% sensitivity. It's about 80% on the sensitivity of the PCR. Therefore, when we have a diagnosis suspicion, I cannot discard hemorrhagic fever because I have a negative PCR. So I have to treat all suspicious cases independently of the results of the PCR. So this is done empirically, and for this we apply the clinical algorithm that we were mentioning before. And the specific treatment that we have is immune plasma that is obtained from people that suffered from the disease, recovered, and through their plasma donations, the plasma that has the antibodies and this passive immunity, we're able to reduce the lethality of the disease from 30% to about 1%. This is a flow chart so that you can see how we react to a suspicious case. The clinician, well, this is a mandatory notification disease, and they have to take all the data of the samples, and they take the form and the sample to our health integrated health system, and this sends an alert to all the authorities that have to make some sort of decision on the case. We get the samples to the Mastegui Institute. Here we diagnose through the live diagnostic. We inform the results through that same integrated system. And the Mastegui Institute is the one that provides the vaccine to vaccinate the population. And they also provide the epidemiological data to decide where we're going to apply the immunization. And then the Institute also coordinates the immune plasma banks network that are in the endemic area so that they can obtain the plasma from the people who have the illness, and through this, we coordinate the delivery of immune plasma for the patient. And you can tell me, out of how many cases are we talking about in a year? This is a report of the cases since 2007. This is where we introduced the vaccine in the national immunization calendar till 2022. And we can see that confirmed cases always vary between 15 and 50 cases per year, which is what we usually have in this period. And we can see that we have a lot of suspected cases, but were not confirmed by labs. These are the ones that are in gray. And you can tell me what happened in 2009 that you had a significant increase of suspected cases. Well, the vaccine should have had the contrary effect. Well, here, what happened is that starting in 2009, we have two events that change or present new challenges in the program. One was the reintroduction of dengue in the endemic areas in Argentina. The reintroduction of dengue. Dengue for us is the first differential diagnosis because it's very similar in its first week in its clinical presentation. So the reintroduction of dengue, and we can see in 2016 to 2020, we have a lot of suspected cases because there was a lot of circulation of dengue in that endemic area. And on the second place, also in that reintroduction of dengue, we changed the way that we did surveillance in Argentina. We started to do surveillance in a syndromic way, to unspecified fever syndrome. And these are all the illnesses that have fever presentations that are similar with unspecified manifestation without compromising airways that can be dengue, leptospirosis, etc. So there was an awareness sensitization in the surveillance system that increased the suspected cases, but we don't see an increase in confirmed cases. And the green line is the lethality. And we can see, if we had the whole history, we can see that despite having the adequate tools to prevent and treat the cases, the drop in the disease that has been significant, because we are saying that at the beginning we had 500 confirmed cases per year, and there we were thinking about hemorrhagic fever, and we had years where we had 8 cases, and the drop of incidence also leads to a delay in clinical suspicion for physicians that have had no contact with the illness. So regarding sex and age, or gender and age, we can see it affects all stages of life, and we see that it's more frequently found in men in active periods of life, but we see progressive increase in women. And something else that we have to pay attention to here is people who are under the age of 15. We see that we have confirmed cases every year, that 10% of the cases are in children under the age of 15, and the problem is that the vaccine is for people 15 years or older, so the pediatric population cannot receive the vaccine. Just timely treatment. Regarding occupation, we were taking that it was mostly rural working populations, but we can see that in the last 2 decades, the rural population, I'm sure, well, first, we've seen a drop in rural populations, and second, they are the ones that are immunized. They have the indication, so only 20% of confirmed cases are rural, and 50% are people who live and work in urban areas that have contact with occasional contact with the endemic areas or wildlife. We also see that there are people who are transporters that work in the interfaces. They do not perceive themselves to be at risk, and that population, we have been working intensively with that population to be able to immunize them. We have three scenarios for transmission when we have suspected cases, and we can see the classic scenario is cases that people who live and work in the endemic area of the disease, and this coincides with the serial export area of Argentina. We also have emergent scenarios. These are new areas where we have never seen a case, and then it appears, and we confirm that the patient caught the disease in that area, and this is also usually in the peripheral areas of endemic area. And then we have the traveling scenario. These are the people who become infected because they are visiting endemic areas, but they do not live there, and in the end, they get sick outside of the endemic area where you do not have an early suspicion of the disease because the health system in that area is not used to thinking about hemorrhagic fevers. An example of the traveling scenario can be seen in a population that has more than 20,000 workers, rural workers. These are migrant workers that we have in Argentina. These are people that travel 3 months out of the year to work in the endemic areas. And we follow these populations. We did research with these groups of workers, and then we did serological tests, and we saw that 50% of them had antibodies for the Junin virus without having immunization and without a historical record of having suffered the disease. So we saw that there was a risk in this population that was directly going to the endemic area to work in the fields. And with that, we created a campaign for education for these populations. We also did training for the health ministries in the origin area, that's Santiago del Estero. So now they have the installed capacity, and now they have vaccinated more than 10,000 workers in that area. In the traveling scenario, we also had, or we were able to export one case to Europe. This is a case that came from Pérez in Santa Fe in Argentina, the endemic area. And this person traveled to Europe incubating the disease, and they developed symptoms during that travel. And finally, they were admitted in Brussels in Belgium. And this person was diagnosed through PCR in Germany. And we, in our program, when they asked us for the suspected case, for us, clearly this was a hemorrhagic fever, and with us, we were able to assess with treatment and management of this patient. And finally, I have to say that the patient was not able to receive plasma because this was a late suspicion, but we did provide Belgium with plasma if any health worker was infected, but they didn't need it, they didn't have to use it, and the patient was able to recover, and now they donate plasma. Prevention measures, again, we have all general measures, individual, environmental, and rodent control. But generally, given that this is wildlife, when we talk about rodent control, we can talk about peri-urban areas, but we cannot really control rodents in nature. So, as I said, it was all meant, we all intended to look for a vaccine that we now have, but can only be used starting at the age of 15, given that this is a vaccine, the live virus, there are some patients that cannot receive it. The vaccination itself is carried out by the ministries of health of the provinces, coordinating with the Argentinian Health Ministry and the Hemorrhagic Fever Institute. So we collaborated with them to create the strategies for vaccination and also to give them the guidelines of the use of the vaccine. But why vaccination strategies? Because even though we have the tools, adult populations do not demand this vaccine spontaneously. The drop in the occurrence of the disease, many times those people who work in urban areas do not perceive themselves at risk, so we have to develop immunization strategies so that we can reach the different groups that perceive themselves in different ways. Then we obviously have searching for timely treatment and a immunized population, we have also developed health strategies for the communities, and we work on training and education for healthcare personnel. We have many courses and trainings that we provide for healthcare professionals so that we can maintain this suspicion active so that we can treat suspicious populations. The national control program that has been working for 40 years meets with all the authorities that belong to the program from the Maestegi Institute and the Ministries of Health in each one of those areas that can be immunization, diagnosis, people working in plasma banks. All of us meet once a year to see what we did well, what we still have to do, the goals for the next year, and this is done uninterruptedly, has been uninterruptedly since the 80s, where a report is created every year, and you can access it in the Ministry of Health webpage in Argentina. You can look at the annual program for hemorrhagic fever, and you can see that there is a call because we still have many challenges ahead. Finally, I finish with this. This is a slide that shows you the emergence of the disease or the isolation of the disease back in the 50s, the presentations of the cases. We can see that when we get the program, we had lab confirmation for more than 500 cases a year, and we can see how at the beginning of the clinical trials for the vaccine, you can see the occurrence that we had for confirmed cases, and well, the vaccination first was directed to the target populations, the rural populations, the male workers, and finally, all of the population in the endemic area in 2007, we introduced it into our national calendar. And you can see the change in the occurrence of the disease. And here we see an increase that the light green is suspected cases, and red we have confirmed cases by the lab. And you can see by the end of 2009 and 2010, you can see the increase of suspected cases, but that are not accompanied by confirmations by labs. And this is related to the sensitivity of the system and the reintroduction of dengue in Argentina. And well, thank you very much. Let me leave you with some pictures of the last meeting that we had this year in Belleville, Cordoba, in the 29th of September, where we met again, all of us who make decisions on Argentine hemorrhagic fever, to talk about the challenges in the future. We still have many, as we will see later. So thank you very much, and I'm here to answer questions. Thank you very much, Dr. Sinchi and Dr. Castellón Gutierrez. We have two short questions. I know there's many more. Many of the questions, I copied them, so if you, and they will be sent to the speakers so that they can answer them directly. One of the short questions is whether Bolivian and Argentine hemorrhagic fevers, if the patients during the incubation period can transmit the illness to others. Dr. Sinchi and Dr. Castellón Gutierrez, either one of you can answer. Well, in my opinion, it's difficult to show. We do not have enough cases to show this. The fever stage is usually the increase of the virus. So the greatest transmission period for the Argentine fever is when the patient has fever, because this coincides with the it has the greatest possibility of transmission. A few days before the onset of symptoms, we do not have case studies to be able to give you an answer. I don't know, Castellón, Dr. Castellón. I agree with that. In COVID, it was the same. Before the onset of symptoms, we cannot detect things directly or indicated, but once we have onset of symptoms, we can see diagnosis through antigens, serology, and PCRs. But we don't have it very well described because we do not have enough cases since 1952 to 2019. That's a lot of time, and we haven't been able to do the complementary studies. But Yes, the transmission begins
Otra
with the
aclaración que
symptoms.
quiero hacer respecto de la
Another thing
transmisión
that I want to
interpersonal
clear up
transmisión
regarding
interhumana es que muchas
transmission,
veces,
interhuman
si
transmission, or
bien
person-person
uno
transmission,
sospecha de
even
transmisión
though there's a
interhumana,
suspicion
en
of
algunos
human-to-human
casos
transmission
no
for some
podemos
cases,
confirmarlo del
we
todo
cannot
porque pueden ser
completely
una fuente de
confirm it
exposición
because
común.
these could
Generalmente
be
cuando
a
las
common
personas están todas
exposure
dentro del área
source.
endémica.
Maybe everyone
Pocos casos que
is in the
nosotros
endemic
podemos
area. The
confirmar
few
como
cases where we
transmisión
can
interhumana
confirm
son aquellos donde
human
el caso índice
transmission
estuvo en
are
el área
those where
endémica y
the
el caso
index
el
case is
segundo
in the
caso
endemic area, and the
enferma
second
luego
case
del contacto con esa
get
persona,
sick
pero
after
fuera
having
del área
contact
endémica.
with that
Entonces,
person
a eso a lo que me
outside of the
refiero con que la
endemic area. So
casuística
that's
para
what I
demostrar
mean
eso no es
when I say
suficiente,
that
porque no es lo
we do not
habitual.
have enough cases
Muchas
to
gracias.
show
Hay
this.
otra, voy a hacer esta como última
Thank you very
pregunta.
much. And this will be
Veo
the
todo el
last
resto de las
question.
preguntas en el chat y
I
son
see
todas
many
muy
other
buenas
questions,
preguntas, pero voy a
and they're all
pasar para
very
la
good
siguiente charla,
questions
las
that
pueden preguntar
we will send them
directamente,
to
pero
the
la
next
siguiente pregunta es si
meeting.
existe
The question
un
is
registro
there
de
a
hemorrágicas en
registry
Sudamérica
of hemorrhagic
con las
fevers
regiones
in South America
endémicas
with
y
the
si
endemic
existe este
regions?
enlace
Is there
donde pueden acceder
a
a dónde está el
link where
registro
you can
de
connect to that
fiebre hemorrágicas en
register
Sudamérica?
for hemorrhagic
Bueno, muy
fevers
buena
in South
pregunta.
America?
Un registro como tal
Well,
no
a
hay, o
registry
sea,
as
no
such,
tenemos
we
un
don't have
registro
one.
como en
We
una
don't
página
have
donde estén
a
todas, o sea,
web
cada
page
uno
where
de
you
nuestros
have all of
países,
them.
si uno entra
Each one
en
in
la
their
página del
country,
Ministerio de
if you go
Salud o en
to
la
the
página del
Ministry of
Instituto Maestegi en
Health, in
Argentina, van a
the
encontrar toda la
Maestegi Institute,
información
and all those
disponible
web pages, you
respecto de
can
los
have
casos y la
the
presentación de fiebre
available
hemorrágica
information
argentina.
about Argentine
Pero
hemorrhagic
sin
fever.
embargo, nosotros
Nonetheless,
desde el Instituto Maestegi, en
we in the
colaboración con el
Maestegi
CDC de
Institute, in
Estados
collaboration with
Unidos,
the CDC in
con
the
el
United
Instituto
States
Gorgas de
and the
Panamá,
Gorgas Institute in
estamos
Panama,
trabajando,
we are
financiados
working,
también por la OPS,
also
en
financed by
una
PAHO,
serie de
we are
guías
working on a
para
series of
el
guides
manejo, digamos, para la
for
vigilancia
the
y el manejo de
management,
las fiebres
surveillance, and
hemorrágicas
management
virales, no
of
solo es por
viral
arenavirus,
hemorrhagic
y dentro
fevers,
de
not
ese
just arenavirus.
proyecto está
And in that
pensado a lo
project,
mejor tener algún tipo de
we are
plataforma
considering
donde se
having
pueda
some
acceder
sort
a
of
todos los datos,
platform where
tipo
you
algo
can
así como el
access
PISA
all the data,
para los
something like
arbovirus,
PISA
pero
for
todavía no
arboviruses,
está listo.
but it's not ready yet.
Doctor Castellón.
Dr.
Sí,
Castellón?
la transmisión en
Yes,
el caso del virus
for
Chapare, nosotros hemos
the Chapare
tenido
virus,
casos
we
que se han
have had
confirmado
cases
y ha habido transmisión de persona a
where we
persona
have
e
seen
incluso
person-to-person
intrahospitalaria, ¿no? Recordemos que
transmission
uno
and
de los
intra-hospital transmission. We
médicos
have
había
to remember
sido
that the one
trasladado a tercer
medical
nivel de
professional
atención,
had been
se le hizo
transferred
una
to a third
endoscopia y
level,
la persona que había
and they had an
realizado la
endoscopy,
endoscopia
and the person that
enfermó
carried out that
con virus Chapare.
endoscopy
Falleció,
got the
¿no? Así que
Chapare
nosotros tenemos
virus. So
más que
we
documentado que
have
el virus de la
documented
fiebre hemorrágica Chapare
for
se
Chapare
transmite de
virus
persona a
that
persona,
it
¿no?
can
Está
be
documentado
transmitted
y
human to
está
human.
descrito ya en el
It's
literatura.
documented and described in the literature.
Bueno, muchísimas gracias. Los invito a que
Thank you very much,
se
and
nos
I
unan en la
invite you
siguiente
to
parte de la
join us
conversación, que
in
va a
the
ser
next part
una
of the
conversación un poco más
conversation that will
informal,
be
donde
a
ya
more
no hay
informal
presentaciones, pero
conversation where we won't
cada
have
uno de los
presentations,
participantes va a
but the
poder,
participants will be
no,
able
no,
to.
no tienen que estar silenciados y pueden hacer las preguntas directamente a los
Well, you
ponentes,
can
pero
ask
copié
the
todas las
questions
preguntas que
directly,
estaban
but
en la
I've also
sección de
copied
Q&A
all the
y vamos a
questions
ver si
in the
podemos,
Q&A,
se
and
las
we will
transmitimos a
see
los
if we
ponentes
can
y les podemos
ask
mandar
them
las
to
respuestas
we can
directamente.
send them to
Muchísimas
the
gracias
speakers and then
y
send
nos
you the
encontramos en
answers
la siguiente
directly.
reunión.
Thank you very much, and we'll see you in the next meeting.